Well, obviously, it was the work at CDC remained important to you because you've been here for almost 20 years now, I think.
Right.
I mean, why have you stayed? What's kept you sort of attracted to?
Well, first of all, at the time that I came here for 2 years, I certainly expected I would go back and finish my clinical training and become a real doc. But serendipity stepped in, and about the time that I was well into my second year as a medical officer, there was a big epidemic of yellow fever in Nigeria in 1969. And Brian Henderson, who was then the chief of the arbovirus unit, had just returned from, I believe, 2 or 3 years doing yellow fever research in East Africa. And he was very excited about this, and I was well aware of the very rewarding experience that he had had in Entebbe. And the opportunity arose then, on request of the Nigerian Ministry of Health, to go to Nigeria, where there was operating the last of the Rockefeller Foundation virus laboratories in Ibadan under Otis and Callista Causey. And this just seemed too good an opportunity to pass up, and I informed Peter Brent Brigham that I wouldn't be coming back, at least not immediately, and went to Nigeria and really continued what Brian Henderson, the sort of work that Brian had done in East Africa, but now in the setting of just after one of the largest of the yellow fever outbreaks in West Africa. And therein began my, what has been a career-long interest in yellow fever. Came back to CDC and took over the unit in 1972.
Do you think becoming director of the unit and then the even larger unit later, think it was a good choice to make at that time in your career as you look back? Or would you perhaps have stayed in the field longer if you had to do over? What thoughts have you had about that?
Well, I think it was the right choice. I wasn't stepping into a high-level administrative position prematurely at that time. The arbovirus section was small, and there were some very good people. Dan Sudia was running the entomology part. Charlie Kalischer was there, pretty much in the same capacity. He was. There were some young people. Steve Bowen was a medical officer, and it was a small group. And I wasn't constrained by a lot of administrative details. I was in the lab a lot. I was able to go out in the field. And so it was an ideal position from which to pursue a continuing and active hands-on approach to arbovirology. So
you have launched yourself studying one of your great loves, yellow fever, in the laboratory. And then you have the opportunity to go to investigate the first of several epidemics that you're going to investigate on yellow fever in your lifetime that continue even now. It was, I believe, while you were in Nigeria that the whole Lassa story started to unfold. And presumably that's how you got involved in Lassa. You want to elaborate a little bit on that?
Yeah, as a matter of fact, it was the same week that my family and I were to leave the little more than 2-year assignment in Nigeria when I received a cable saying, proceed to Zorzor, Liberia, do not pass go. There's a presumed Lassa fever outbreak. Now, at that time, that was 1972, and as you well know, there had been a couple of prior nosocomial outbreaks of Lassa in Nigeria, and I was familiar with that background, but I'd never done any work on Lassa. So I flew to Liberia and went to Zorzor, where it's the mission hospital, and a very astute missionary physician, Paul Mertens, had recognized that this was probably Lassa. An American nurse had died, as well as a number of midwives and midwifery students at this small mission hospital up country. And specimens were flown back and the diagnosis was confirmed, and together with Mertens and Randy Moser, who was with the smallpox program and was stationed in Liberia, we conducted a series of investigations, resulted in several papers on the clinical and epidemiological features. This was a classical nosocomial epidemic, very similar to the ones that occurred in Nigeria. I think it was 5 or 6 months later that word came along that there was suspected outbreak of Lassa in the eastern province of Sierra Leone, the same place where you, of course, have been engaged in some very important studies in recent years. And I recognized at that point that this was a great opportunity, and put together a multidisciplinary team of people, which included not only CDC people, but 2 individuals from Yale, Dr. Jordi Casals and Graham Kemp. And I think there were a total of 6 of us, including 2 young EIS officers who are now well known in their own fields, Dave Fraser and Kent Campbell. And we went to Panguma. The outbreak was centered in a Catholic missionary hospital in Panguma, but it was apparent early on that this was not a typical nosocomial outbreak, and only a small fraction of the cases could be traced to infection acquired in the hospital itself. Rather, the disease, most patients had apparently been infected at the village level. And so, together with Graham Kemp and Vern Newhouse and I really focused a lot of attention on making systematic collections of animals from case households, and that resulted, of course, in a collection of some hundreds of rodents over over about 3 weeks, and the isolation of multiple strains of Lassa from a single species out of many that were collected, and the implication of Mastomys as the reservoir host. Well, at that time there was a reorganization in CDC, and I left Atlanta and the opportunity to work with the high security laboratory in hemorrhagic fevers, and went to Fort Collins, which was of course engaged in research on a wide variety of viruses, but in particular the encephalitides, which are the principal causes of human disease in the United States. And so I began to focus more of my attention on St. Louis encephalitis and the other encephalitides. It wasn't long after I arrived in Fort Collins that we had the biggest of all epidemics of St. Louis in history, which occurred in 1975, with over 2,000 reported cases, and our laboratory really turned essentially all of its attention and all of the various disciplines, entomology, diagnostics, molecular virology, and so on, to the problem of St. Louis encephalitis. And so I became interested in particular in that virus, and became involved in a series of investigations looking at strain variation of St. Louis encephalitis virus. Our group in molecular virology began to fingerprint St. Louis encephalitis virus strains and use other techniques for distinguishing them. And I interested myself in looking at biological differences between St. Louis encephalitis strains, and we did some systematic comparisons of virulence in mice and birds and monkeys that I think have really set the pace for, or set a biological framework which has allowed us to pursue questions of virulence at the mechanistic or molecular level, which have continued in our lab. I got interested also in the old controversy of how the encephalitis viruses invade the central nervous system, and extended these studies on virulence, having developed model systems with which to work to readdress that question, and did a study which I think provided some somewhat different insights into the pathogenesis of flavivirus infections, showing that, at least in a model of St. Louis encephalitis in the hamster, that whereas viremia is important in the pathogenesis, that virus in the blood is responsible for infection of a selected subset of neurons that is not protected by the blood-brain barrier in the olfactory epithelium, and thereby gains access to the brain rather than other ways in which the virus can cross the blood-brain barrier more directly. Whether or not this is generally applicable to human disease is still uncertain. But it also raises some very important issues regarding immunization. One of the problems we face is that we currently use a number of experimental vaccines to protect laboratory workers whose exposure is different from people exposed to arthropod transmission in the field. Their exposure is often by the aerosol route. And it's becoming increasingly clear that parenteral immunization, especially with killed or subunit antigens, may not result in protection against exposure by the aerosol route. And so this may fit with the role of the olfactory epithelium, the need for mucosal immunity and protection, and some real differences at the molecular level that are important in stimulating humoral versus mucosal immunity that we need to take into account. So I think these early observations really need to be extended now, and they become increasingly important as we get into the development of vaccines against these infections.
Is this, in fact, work that you're continuing to do in your own laboratory?
Well, we certainly are in Fort Collins. We're very interested at this point in Venezuelan encephalitis. It's probably will be the first recombinant arbovirus vaccine that will be used. It's been developed in our lab. And one of the problems is that non-replicating immunogens, such as vaccinia recombinants of VEE, which stimulate very good immunity in the host, do not protect against intranasal challenge. And so we're up against the same problem in that system, and it's one that we're continuing to address.